So there are few people who are practicing. It's good. People who just joined. I was just showing the trend in U.S. data of how the tubes and shunts have been on the rise over the years. So this is the trend now. The questions have gradually increased for various reasons. Failure of trabeculectomy over the years, and then you have a lot of other options. But in spite of that, shunts have a very, very good role, especially in cases where you have all these problems, new vessels in the iris. It's already an operated eye in the form of keratoplasty or previous surgeries, a retinal surgery, eye syndrome, uveitic glaucoma, traumatic glaucomas, where there is high risk of failure of doing a trabeculectomy, where you can get a membrane or a hemorrhage which can cause the fibrosis of the bleb. And there are certain other indications where we often try when an open angle repeated trabeculectomy has failed. There is a downgrowth of epithelium, sometimes even an infantile glaucoma which is refractory, syndromes like Sturge-Weber. And then finally, there is always a debate on primary glaucomas, whether we need to do a tube shunt. But still, I think people would feel gold standard trabeculectomy is the way to go. But there are some people who do primary tube shunts also. So Ganesh very well pointed out, meticulous planning is very important, especially when you have both the options in your hand now, the RD or the bare-walled implant, which is now available, very cost-effective. The AGV, it is slightly more expensive in our scenario. If you see the cost is like 1/5, you can get an RD. So you have to carefully choose depending upon what patient you're going to treat. So what kind of pressure you need, immediate post-op control. You can make a choice between a tube and a valve. And the location, of course, is very important. Where do you want to put it? Depending upon the previous surgery, scarring of the conjunctiva, whether you want to put it supratemporal or in the infranasal quadrant, which are the two common quadrants. And then site of entry, where you're going to enter into the anterior chamber, how long the tube has to be, how do you cut. So definitely that kind of wet lab practice will avoid situations like this. This image I saw some time back. I think they wanted to play a cross game inside. There are 2 tubes. And I've seen people having 3 or 4 tubes also in some of the practices in US. But definitely I think if you can master this technique and play in the wet lab before you start practicing on human eyes, I'm sure we can avoid a lot of issues related to tube erosion, hypotony, and all other complications. So I basically would like to highlight in AGV and also in tube the top 5 pearls related to conjunctiva, where your plate and tube should be. How do you avoid a kind of having this dreadful complications like hypotony and a shallow chamber? How to avoid a corneal touch? And the most important part in AGV is the cyst, which is notorious to happen more common in AGV than in the RD, because of the circumference, which is not much. The square millimeters is almost half of the RD. So the chance for Tenon cyst is very high. And how do we avoid it? So conjunctiva is very important. So where do you want to do the surgery? I think it's very critical. A lot of times, when you have previous VR surgery or previously the conjunctiva is meddled a lot, you need to carefully select the quadrant, because this closure is very critical. Sometimes you put an implant like RD or a valve, then it is very difficult to close the conjunctiva. You have a very tough time. So I think it's very important to select the quadrant. And if there is a previous supratemporal surgery somewhere in the superior quadrant, I think it's always good to go inferiorly. You can very comfortably do the surgery in the inferior quadrant by isolating the inferior rectus and the inferior nasal muscles. You can comfortably place the implants. And especially if the conjunctiva is very thin and if it is scarred, you should widen the initial incision, and you can free the Tenon's capsule also, so that you can go as posteriorly as possible for the closure. So if there is an extensive scarring, these are the important points I think we should keep in mind. If the conjunctiva fails to reach the limbus when you are trying to close, you can do additional dissections to reach the missed additions. You can separate the tenons and create a kind of posterior peritomy so that the conjunctiva can slide forward. I mean, little bit of practice you can do this, and leave a gap of less than a millimeter to epithelize. So that gap also can help you to epithelize over the cornea. And if you think there is extensive scarring even after dissection, it is nice to close it and then choose another site so that after putting the implant, you will not have a tough time in closing the conjunctiva. So when coming to plate and the tube, as far as possible, you have to make sure it is posteriorly placed, especially in AGV, at least 8 to 9 millimeters from the limbus, and suturing the plate with a lot of patience. I think again that wet lab practice will help you, and how to very safely take it in the sclera and then go through the hole in the tube shunt is very important when you are doing it. So you need a nice exposure. So the lateral cuts in the conjunctiva also will give you a nice exposure. So make sure you don't fix too deep, which can cause perforation in the sclera. And very importantly, I think when you are inserting the tube, again, you should make sure when you are entering into the anterior chamber, when we are learning to enter, if you are too superficial, definitely the tube may touch the endothelium and it can cause a decompensation in a later date, trying to get our cornea people to blame us. So you have to be equidistant between the cornea and the iris so that the tube doesn't touch either the iris or the cornea. Again, if it is very close to the iris, you can have the iris stuck to the tube, and then it can even close the tube sometimes, which needs a release. And when you are covering the tube, there are various ways. People, if you have access to things like pericardium, of course it's good. But normally, if you get a sclera, it's a nice thing to close with sclera. If you have a eye bank and you have an access to sclera, that is the best part. And again, cornea, if the corneas are available, they are not used for keratoplasty, then I think that's an ideal situation. You can split the cornea and close it. The biggest advantage in cornea, because it is transparent, you can see what's happening under the tube, especially if you are putting a suture, you know when it is getting lysed and things like that. And as far as possible, also you can try to make a long tract so that you don't need even a patch to close. There are several people who do that. So I'll just show you now how we normally do an AGV. This is which is done in the supratemporal quadrant. A nice conjunctival dissection is done posteriorly so that you have and then I normally use mitomycin. Again, the idea is to prevent the cyst. So you have to place the mitomycin really posteriorly. You cannot place it like how you do in a trabeculectomy. So you need to place it where the valve is going to be placed. And then you have to carefully suture the plate to the sclera. Again, keep in mind how deep you are going and how you are suturing. And make sure it goes into the core. Sometimes in AGV you can even go through the implant. So make sure it goes through the hole in the implant. And then as you see here, the bevel up is very important when you are cutting. And then I use a 23 gauge needle. Slightly I make little longer track, but not very long enough because I have something to close the tube with a patch graft. So very important when you enter into the anterior chamber, make sure you are slightly away from the cornea and not very close to the iris, so that your tube will neither touch the cornea nor the iris. And then carefully insert. So there are tube holders which will really help you. And then the most important point here when you are entering into the tube is if you can really zoom it up, it will be very nice. If you can really zoom your microscope, you can see that ostium very nicely when you are entering into the anterior chamber. And then this is just a tube anchoring suture to the sclera. Normally in an AGV, you don't have to ligate the tube like in an RD implant. And now you can see me using a donor sclera, which is cut depending upon what size you want to close, maybe a 4x4 or a 5x5 millimeters. And you have to anchor it nicely with a non-absorbable nylon sutures. And then this part is very important. You'll have to pull the conjunctiva, make sure that reaches the limbus. That is very important. And then you start suturing it. So you have to really have an watertight closure, very meticulous closure, so that it doesn't retract. So most of the times when you are not closing it properly, the conjunctiva can retract and cause a lot of complications in the later date. And you can see I normally try to place the tube in a slightly angled position like this so that it doesn't go into the pupillar area. At the same time, you have a long tube to visualize what is happening in the anterior chamber. This is the immediate post-op which you see in a couple of weeks' time. You can see a little bit of epithelialization happening. The sclera is quite prominent. A lot of times cosmetically people not be happy when there is a white part exposed. They'll be complaining on it. You have to alert them before. And the advantage of a corneal graft is if you have a corneal patch graft, definitely you won't see something like this. It will be more transparent. And how do you avoid hypotony and a shallow chamber? the needle track is very important for that. If you're going to make it a bigger track, you will have peritubular filtration. Peritubular filtration is notorious for having a hypotony in the immediate postoperative period. So make sure you don't go beyond 22. So ideal size is 23 gauge. Now many times when the people have difficulty in inserting the tube, they try to enlarge the ostium. That ostium is quite notorious for a peritubular filtration. So you have to keep in mind. And if there is any leak close to the track, it's better to close it and then make a new track. So if you make a slightly longer tunnel, you don't have to close it with anything. It will just close like by the effect of fluid pressure inside. But if you are making it very close to the limbus, you need to put a small patch and then make a new track, which is very important. Otherwise, invariably you will have a little bit of hypotony and shallow chamber. And again, you should try to avoid kind of corneal touch. So wherever needed, I think you can do implants in different sites. You can make a very long tract at the limbus area, or in pseudophakic eye, you can be into the sulcus. You can put the tube into the sulcus, or again in vitrectomized eyes, you can put it into the pars plana. You have pars plana tubes for AGV. The technique would be the same. You have to anchor the plate posteriorly, and you have to use the 23 gauge needle to go into the pars plana and insert the tube. You can use a normal AGV also. You don't need to use a pars plana tube with the pars plana tube in all cases, but if you have that, you can always use. But basically, I think you can use the normal FP7 or FP8, whatever you're using, in an aphakic eye. So that this really helps is because already in an aphakia, there will be a lot of chance for the cornea to get decompensated. So if you can work on this tube which is posterior, I'm sure you can avoid this kind of problem. So you can see here the same 23 gauge needle going into the pars plana area, and then you at this point is very important. As I said, if you after you make the needle track, you need to really zoom up to see that ostium very nicely. So once you zoom up your microscope, you can very comfortably insert. This is one point where I find a lot of the trainees find it difficult when they are learning to insert the tube. So that is the point I think I would like to again highlight, and then finally closing the conjunctiva. So there are people, especially the Dr. Oscar from Mexico, he does the long track and he totally doesn't put any patch on the tube, which is very, very effective. He has done thousands of eyes like that, and he says it's very effective. There is no exposure, there is no erosion of the sclera, and the results are pretty good, and a very short time you can do that. And you can see some of these. So if you can make something like this, not really long, but away from the pupillary area, if you make a track like that, it will be really very helpful in the eye on a long term. So the last point, I think I should insist, how to avoid the Tenon cyst. That's a big question. Almost, if you see several reports, 1/3 of them have Tenon cyst. But there are several ways by which people have advised to get rid of this. So some people have used tube ligation suture even for an Ahmed glaucoma valve. So basic thing is you should not allow the aqueous to stay around the plate for some time, for 5 or 6 weeks. Because once the aqueous is there, the risk for the Tenon cyst to form is high. So you can put the patient on aqueous suppressants, or you can ligate the tube and see whether it works. The other way is to use the mitomycin, which normally many of us use. And this is a report which came recently. It's a very smart idea. They say the results are pretty good. They put the mitomycin sponge on the implant and then place the implant for 2 or 3 minutes with the mitomycin sponge. So they found that by putting it like this, exactly at the implant area, you have mitomycin application. It looked like a smart idea. I have not tried this yet. I cannot say how it worked with me, but their results are pretty interesting. So this is one way you can avoid the cyst. So if you can avoid the cyst, you can have beautiful blebs like this, and many of these patients do very well for years together with these implants. Thank you.